Thank you for attending what will be a fantastic seminar today. So I'm just going to give a very brief introduction about Newcastle Health Innovation Partners, which is Newcastle's academic health science centre. It was awarded back in 2020, recognising the strong partnership, particularly from an academic perspective, between Newcastle University, Newcastle Hospitals, Newcastle City Council, and the local mental health trust. My role in NHIP is to encourage collaborative interdisciplinary research and innovation between the various partners. And one of the areas we have chosen to do that in, again, representing our strengths, is advanced therapies. And we call this the Advanced Therapies Satellite. And this is the Advanced Therapies Satellite seminar series, where we have a different renowned international speaker to tell us about what they're doing. So thank you for attending. That's all I'm going to say. Do keep attending these seminars because they're always really worthwhile and good value. But I'm now going to hand over to Kat Hilkins, who's going to introduce today's speaker. So thanks, Kat.
Okay, well, Ed, it's a real pleasure to introduce Ed Geissler today as today's speaker for the NHIP Advanced Therapies Seminar. So Ed received his basic and postdoctoral training in transplantation research in the USA at the University of Wisconsin. And I think it's over 20 years ago that he moved to Germany, to the University of Regensburg, where he's the head of experimental surgery. Now, Ed is really well known globally for his work in transplantation immunology, and I think he's particularly recognized for his work in translating basic concepts into high-impact clinical studies. Now, one of these studies, which I'm sure Ed will talk about today, is an international study called the ONE study. By the way, I still think that's really a fantastic name, in which different immune cell therapies were evaluated in kidney transplantation patients with the goal of reducing the burden of immunosuppressive drugs for these transplant patients. So we are really very pleased, Ed, that you've agreed to give a seminar here today about your groundbreaking work in the field of transplantation. I'm looking forward to it.
Thank you, Catherine and John, for the introduction. It's a real pleasure to be here today. And I hope I can bring you up to date as to what is going on with regard to cell therapy in kidney transplantation. What I would like to do, and I'm always speaking, I guess you could say, from the standpoint of a transplant immunologist, where we're trying to induce or trying to prevent the rejection of organ allografts. Some of the same concepts, of course, apply for autoimmune diseases, which many of you deal with. But in organ transplantation, and also in all types of immune disturbances, what we tend to do is block the immune system. We over many decades have found many clever ways to inhibit the immune system by blocking certain pathways, right? With the calcineurin inhibitors, mTOR inhibitors, et cetera. So we're always trying to block either molecules or pathways. We're trying to block aspects of the immune system. But what I like to really think about is cell therapy in a different context, that what we're actually doing is adding in an immune function. And this is really different and maybe in some ways revolutionary to at least organ transplantation, where we're trying to add in a regulatory cell function that can then regulate that response against the allograft. It's a really different type of concept, and I think it's important that we think about it in this way. So as Catherine already mentioned, it's back, 14 years ago now when I started a project that was funded by the European Union called the ONE study. And if we take ourselves back to around 2010, there were not a lot of immune cell, T cell based, macrophage or monocyte based therapies out there that were developed at that time. So our job in the ONE study was to develop these cell therapies to the point where we could apply them in solid organ transplant recipients, and in this case, in kidney transplant recipients. So what I tried to do in the one study at that point was to bring everyone together that was trying to do this. No one was really doing it at that point. And I thought if we put our heads together, maybe we can make some progress along this line. So our consortium consisted, again, this was an EU FP7 funded project, which was obviously based in Europe. But we had a number of countries involved, including the UK, as you will see, France, Italy, and the United States was also involved in this project. And maybe that helped, since I come from there and I knew a lot of these people that were doing this type of work, I could bring them on board. And in fact, they asked if they could come on board after the project had started because they liked the idea. And so I think that's a nice part about the one study. It's not just Europe-centric, it's really an international effort to try to bring cell therapy to organ transplantation. It was nice to bring all of these heads together. And just up front to show you the one study, the main publication, the first publication that came out was published in The Lancet a couple of years ago. And basically is this publication is putting together all of the data that we got from the different clinical trials, which I'm going to mention to you, and put all of this analysis together and tried to draw some conclusions from all of that work, which really occurred over almost a 10-year period. So what we had in the one study were 6 different cell products, okay? 4 of those cell products were based on, were a T regulatory based cell product, and 2 of the cell products came from monocytes derived from the blood. So with regard to the Tregs, we had 2 different cell products, and each of these 6 cell products represented an individual trial that was done where these cells were used. So in the UK, London and Oxford put their efforts together and had a polyclonal T cell product, which was actually a frozen cell product. The Berlin group had a similar product, but this was a fresh polyclonal T cell product. The 2 American sites had an antigen, or kind of a donor-specific cell product that was developed in very different ways. One was at the UCSF in San Francisco, the other was at the MGH in Boston. And we had the 2 monocyte-derived products, okay? One was a tolerogenic DC, which many of you are familiar with, and Catherine and John, of course, work with these cells, and regulatory macrophages, which we were working on here in Regensburg. All of these cell products were derived from blood that was taken via leukapheresis products or through whole blood that was taken from the patients. So what I thought was very important when we started the one study, and compared to any kind of not trials, but investigations that were done before that, we needed a control group. Because if we don't have anything to compare to, there's really very little we can derive from the results except maybe some safety data. And even that is questionable when you don't have a control group. And so what we did is we try to follow along, because this is kind of a key slide here. We have what is called a reference group trial that was performed at all of the sites in the one study. Okay, this was a multi-center study. And what we basically did there is what we consider kind of a standard protocol for non-high-risk patients. So for your average patient, which would be basiliximab induction therapy, steroids that are tapered away by 3 months, and continuous therapy with MMF and tacrolimus. This is kind of a standard therapy, at least in Europe, and mostly in the US as well. And so we performed this trial together. And we did this while we were developing the different cell products, these 6 cell products that I mentioned in the previous slide. And so what we have is that trial, the multi-center trial, which is our control group, our reference group, and we had the 6 individual trials. And this is one of the reasons we call it the one study, where I like the name, because I wanted everyone to follow exactly the same procedures we were doing in the reference group trial and use the backbone of that protocol for the cell therapy trials. But each of the different cell products will be put into an individual trial using that backbone. And so the backbone, again, is exactly the same. We did exactly the same everything in the individual 6 cell therapy group trials compared to the reference group. The only differences are we dropped the induction therapy with basiliximab. That's number one. And second of all, at 9 months after transplantation, we allowed, if the physicians were felt secure enough, to wean off that MMF to tacrolimus monotherapy. The reason we kept this optional is we couldn't get all different centers and nephrologists to agree to do this. Some of them felt it might be too risky to take the patients down to monotherapy, and so we made it an optional type of procedure. So that's the backbone of the one study, and this is what I'm going to go through in the next few slides. So what we did is this is the RGT as the reference group trial, our control trial, and the CTG are the cell therapy group trials. So the 6 individual trials. What we did in this Lancet paper, the first paper, is we combined all of those results. The individual results for each paper come later. So in the reference group trial, we, in the end, were able to get 66 patients into the study, 61 of which completed the trials, the trial. And in the cell therapy group trials, we enrolled 60. We treated 38 with one of the different cell products, and all 38 completed the trial. So it's quite successful that we could get so many patients in, and we were quite happy. Now, the reason for this gap between 60 and 38, I'll come to in one of the later slides. Why weren't they all treated? So again, one of the ideas of having a control group is that we would be able to look at the demographic data and basically enroll the same types of patients in the reference group trial as in the cell therapy group trials. Of course, there's no time to go through all the details of the demographics here, but suffice it to say that the demographics of the reference group trial versus the cell therapy group trial was very similar. So we're really talking about apples to apples in terms of recipients that were enrolled in these various trials. Now to the results. In the reference group trial, what we found and what we predicted based on our protocol is that we would have a rejection rate of somewhere between 3% and 18%. There is not really perfect data in order to predict this, but we predicted it based on what data was out there. And so we came up with a range of about 3 to 18% from a statistical standpoint. And actually what we found in the reference group trial with these 66 patients was that we had a rejection rate of about 12 to 17%, depending on whether you're looking at the intention to treat population or the per protocol population. And so we were nicely within this range that we predicted. And so that made us feel like we had a meaningful comparator for our cell therapy group trials. This was quite a good result, something we were happy with. And you can see here the distribution of patients within these 6 different cell therapy trials. Now, I should mention that in the cell therapy group trials, the London and Oxford groups combined their results together. In the reference group trial, they recruited their own individual patients at their own individual sites. So you see 7 bars here, but there are only 6 cell therapy group trials. So in the protocol, something I didn't mention is when could you apply the cell therapy in relation to the time of transplantation. And what we decided is to make this flexible in terms of number of cells that you wanted to inject. You could do a dose escalation. You could kind of do what you want, as long as you did that infusion sometime between about 1 week before transplant and about 1 week after transplant. We wanted the cells to be infused in this window. And basically we stuck to this. And so you can see the different infusion days. from the different cell therapy group trials and the different doses that were put into the patients, which did vary quite substantially from site to site. So here are the kind of the results of the cell therapy group trials. So again, 38 received cell therapy, and we had a rejection rate of 15.8% in the end when we combine the data from the 6 trials together. And again, you can see that the London and Oxford group, their results are really considered combined together for the purposes of the one study. But the rejection rate of 15.8% was for us a good signal, because basically we could get a rejection rate that was identical to the reference group or a control group without induction therapy in the kidney transplant recipients. And as you'll see, about half of the patients could be withdrawn from MMF down to TAC monotherapy. And in the reference group trial, of course, all the patients were kept on the dual MMF TAC therapy for the entire period. So when did the rejections occur? Did we see any differences when they occurred or how they occurred? And the fact is, these are the results that we published in the Lancet. The rejections occurred early, as they normally do in a kidney transplant recipient, whether you look at the ITT population or the per protocol population. The pathology, as far as the types of rejections that occur, were very similar between the reference group and the combined cell therapy group trials. There was really no difference here. And I should mention that this was done by a central pathologist. And so these data that we have were all, everything we put into the Lancet paper was data from the central pathologist, not the individual data from the local pathologist that they found. We wanted this to be harmonized. Another thing, of course, for kidney transplantation is the development of donor-specific antibody. This is a real big concern, one of the real hot topics in organ transplantation today, in kidney transplantation at least. And we thought, because we're not doing induction, we're trying to taper the patients down to monotherapy, maybe we would have more DSAs develop. But we didn't see that. So we saw basically the same rate of DSA that developed at the end of this trial period. Another thing that we were thinking about and maybe concerned about is we thought when we were sitting together, what might happen is that the nephrologists that in the patients that receive the cell therapy without induction, or in the patients that were tapered down to tacrolimus monotherapy, the nephrologist may be tempted to tweak up the tacrolimus dose in the patients, the CNI dose, to kind of cover for the possibility that they're under immunosuppressing the patient. But what we surprisingly found was actually, if you look at the data here on the top is the tacrolimus levels, you can see that actually through almost the entire period, the tacrolimus levels were lower, kept lower, in the patients that in the cell therapy group trials versus those in the reference group trial. And you can see here this big dip at 9 months with the MMF. And of course, this is due to the fact, and I'll talk about this, I think, in the next slide, about the patients that were tapered away from MMF down to tacrolimus monotherapy. So these patients definitely did receive lower levels of immunosuppression during the test period of the one study. Yes, and here's the MMF withdrawal data. I should mention that, and I did kind of allude to this earlier, that the nephrologists were nervous about taking the patients down to tacrolimus monotherapy. And so at the beginning of the trial, many were hesitant to do that, and they didn't do it. And then a few of them did it. And as time went on and more patients came into the study, and the sites could see that there were not any negative signals from those patients that were taken down to TAC monotherapy, more and more of the sites started to take their patients at 9 months down to tacrolimus monotherapy. So I think we would have had even more patients down on TAC monotherapy if they would have felt more comfortable at the beginning. But in the end, 45% of the patients underwent MMF withdrawal to tacrolimus monotherapy. And when I say tacrolimus monotherapy, and you could see that in the previous slide, was actually even lower levels than they used in their standard protocol, in the reference group trial. A couple of patients did have some events that occurred, only 2 of them, and they easily recovered once they were put back on triple immunosuppression. So I would say this was very successful, and I think everyone was surprised by how many patients we could get down to TAC monotherapy. And I'm going to come back to this point a little bit later. Now, one of the very important parts of the one study that came out in the end was regard to the adverse events that occurred. So in general, of course, we did a very, very thorough analysis of the adverse events that occurred. And in general, when you compare the reference group trial patients to those in the cell therapy group trials, there was essentially no difference in the events, the number of events that occurred. And if anything, there were fewer in the cell therapy group trial. But what really popped out at the end, and I can honestly say we didn't even look at this until the trials were over, was this data that the infections in the patients that were in the cell therapy group trial, the blue bar here, versus the reference group were much fewer. Many fewer of these events occurred. And so I was really suspicious of this, to be honest with you. I mean, this is something we would hope for, right? Because we want to lower immunosuppression, lower the potential for them to develop infections, et cetera, from the lowering of immunosuppression. And so we did a really thorough analysis and really confirmed this data in some different ways. What we could see is that the patients across the different sites all showed a decrease in the number of infections that occurred. And this decrease was evident throughout the entire course of the clinical trials that we conducted. Now, when we looked at the different pathogens, that they were the typical ones. They were viral infections, CMV, BK virus. These were the ones that essentially were kind of wiped out or really taken down to very low levels in the cell therapy group patients. Now, what we don't know from the one study is, did this have anything to do with the cell therapy or the cells that we were using? And my guess, to be honest with you, is if you look across here, if all of the different sites with all of the different cell products saw a decrease, chances are it has more to do with the reduction of immunosuppression than an actual direct effect of the cell therapy. But of course, this is something we're going to have to look at in trials that will be done in the future or are being done presently. As far as immune monitoring, we had a huge immune monitoring program, and I'm really not going to go into many details about this, except to say that we did this in a very centralized and standardized way from all of the trials. We collected the samples in the same way, we stored them the same way, we analyzed them the same way, very centralized and standardized. We published this in the Lancet paper as well. Some things came out. Again, I'm not going to go into details, but cells that we would like to see that tend to be associated with tolerance or a reduce in immune reactions towards different antigens would be the marginal zone like B cells and the PDCs. The plasmacytoid DCs have been associated with good outcomes in kidney transplantation. So we were happy to see that these marginal zone like B cells and the PDCs were higher in the patients that were receiving the cell therapy compared to the reference group trial or compared to the levels that they were at the time of transplantation. Birgit Savitsky, who did a lot of these analyses, said that their parameters for these different, for the PDCs and the marginal zone B cells were much like a normal adult would be. And so we thought that this is kind of a normalization of these parameters and something that we would like to see. Now, another thing we did in the one study was to at least in some of the trials, was to look at the numbers of regulatory cells that we saw post-transplant. And this was done probably the best in the UK trial in Oxford and London. They had a dose escalation trial from 1 to 3 to 6 to 10 million per kilogram that were given to the patients. 3 of each were given these doses. And it was really nice to see that the numbers of Tregs we saw in the circulation of those patients exactly correlated with those doses. And the reason I think this is important is because it means we did get some regulatory cells into these patients that reflected the doses that we were giving them. So I think that this was a really a good analysis, and we were quite comfortable with the fact that these cells were at least around for a while. We weren't able to track them for periods of time, but we could see that their numbers, at least in general, not necessarily the cells we put in, but the numbers of T regulatory cells in the circulation were greater. And I'll come back to this as well, but as a result of this, in the UK trial really went extremely well. It recruited as expected, and they had really good results. They had no rejections. As you can see here, they had rejection-free survival. I'll come to that as well because they've published their data. And now they're doing a spin-off of the one study called the 2 study, which is basically an extension of the 1 study, just including a lot more patients. And I'll come to that later. So to the individual trials now. So this is the trial from the UK. These results were published in AJT a couple of years ago. And I can give you a little bit of an update about the results from this trial. I just want to mention a few facts that they published in their individual papers. So 4 of their 12 patients were minimized to TAC monotherapy. All of the patients that received cell therapy, 100%, have rejection-free survival. And about 78, 79% of the patients in the reference group trial from their individual sites in Oxford and London actually did have a rejection rate. So it's a low rejection rate, but a rejection rate that is typical for kidney transplant recipients. This did not develop in any of the 12 patients that were treated with their polyclonal T regulatory cells. And to update this, I just talked to Paul Harden recently. All of these patients now are out 8 to 10 years, even the ones on monotherapy. And he said he's been able to keep them on monotherapy. And I think he even said he has a few more of them now that are on monotherapy, and they're doing extremely well. So this isn't something that was something they saw only in the first year or two, but is something they've seen now over the course of a decade because they have this long-term data. One interesting thing that I would like to point out is in the kidney biopsies that they have taken, and this is at the time of the decision to taper away the MMF to TAC monotherapy, they saw these collections of lymphocytes in the biopsies. And this is something that has been found before in patients that are tolerant. Of course, no one knows exactly what the meaning of these infiltrates are, but it's interesting that they saw these. And they also saw a lot of T regulatory cells within these infiltrates, and they put this is in their manuscript as well in their publication. Now, this is data from the group at the MGH in Boston. They had they treated only 3 patients, unfortunately, because they had some problems with their manufacturing of cells at the site, but they did treat 3 patients with the donor-specific T regulatory cells. All 3 of them were tapered down to tacrolimus monotherapy, and I can tell you that all three patients are now out 6 to 8 years and are still on tacrolimus monotherapy. And this was just published a few months ago, and so this is relatively recent data. So they had really good results as well there, even though it was on just a few patients. Interestingly, they saw these same collections of cells within the biopsies, and these had many T regulatory cells within them. We still don't know what the meaning of these are, but it is kind of consistent that we saw them here on the right. You can see where they stained these for T regulatory cells, and you can see that they're scattered within these infiltrates. Just to mention, not about T cell derived regulatory cells, but cells from NANT, which were toll DCs, which I know you're all very interested in. They had kind of mixed results. This was published in Kidney International just recently. And they had a little bit mixed results because they did see in the 9 and the 8 patients that were treated with the cell therapy, that about a quarter of them did have rejections, all that were controllable and reversed. And since then, actually, they've been able to get, at the beginning, they had 2 patients on tacrolimus monotherapy, and they've eventually gotten 5 more of the patients on tacrolimus monotherapy over the course of the first 3 years. So they've been pretty successful, although they were certainly not able to have a rejection rate that showed any trend towards being less than what they saw in the reference group trial. They did see some interesting immune monitoring things like increased FOXP3 expression, reduced CD8 T cell activation, but was not negative results for sure, but not clear that these cells were having a positive effect necessarily in these transplant recipients. But you have to remember, we're comparing to patients from the reference group trial who were treated with a standard protocol. So it certainly wasn't worse than what we would see in the patients that are typically transplanted under normal immunosuppression. There's another trial I'd like to mention here, the one from Berlin. They were able to get almost all of their patients off of immunosuppression. This was published in the BMJ. So they also had kind of a successful outcome from the one study in their group of patients in their trial. We published in Nature Communications from our trial with regulatory macrophages that we were able to show that we could induce iTregs that were TIGIT positive in the patients, the 2 patients that did receive MREGs at the site here in Regensburg. So in the last few minutes, I'd like to tell you about what other trials are going on and what's happening. Of course, there's a lot of interest in new trials that are spinning off from this or coming. And of course, the possibility of using CARs, donor-specific CARs in kidney transplant recipients. So I'd like to go through that a little bit with you. So here's one of the trials. It's kind of an interesting one. It's a little bit different concept than the one study, of course. This is an individual trial, which is being conducted in Vienna. It's still ongoing. And this one's a little bit complicated, maybe a little bit too much to absorb in this very singular slide here. But basically what they did is they tried to use T regulatory cells to enhance chimerism after transplantation. We know in organ transplantation, if you can establish chimerism and maintain it, you get tolerance of transplant recipients. This is something that we do know. And so what they wanted to use based on some results they had from small animal experiments is use Tregs to enhance the rate of or the amount of chimerism that developed in transplant recipients. And so they did kidney transplants in patients, 6 patients so far, and I think that's all that they're going to do actually, where they have regulatory cells from the recipient, they have stem cells, bone marrow cells, I should say, from the donor. And what they did is, if you look at the protocol here, they did a leukapheresis, expanded the Tregs. Actually, the Tregs were manufactured here in Regensburg, so it's a cooperation between Regensburg and Vienna. And the cells were then shipped back to Vienna, and they were infused at the same time after transplant, day +3, as the bone marrow. And basically the endpoint was looking at whether the rate of chimerism in these patients, donor cells in the recipient, was increased in the patients that received the T regulatory cells. Now, we don't have the results of this trial. This trial is ongoing. I know that they have seen, having talked to Thomas Weckele and Rainer Oberbauer, that they are seeing some enhancement. I think it's at a low level, but I guess we're going to have to wait for the results there. But this is a Treg trial that's ongoing. These are ones that I plucked basically from the clinicaltrials.gov website. Of course, there's the 2 study, which I mentioned to you, which is an extension of the 1 study. They have a control group, a reference group, which is planned to have 34 patients and another 34 patients that receive T regulatory cell therapy. They're about 65% through this trial, so it's recruiting quite well. We're going to really be anxious to see what the results are. That'll probably be a couple of years away, but this is ongoing and working really well so far in terms of conducting the clinical trial. There are some other ones. This is actually one that has been conducted in Lexington, Kentucky, using polyclonal T regulatory cells. It's actually completed. I don't have any information about this. Where basically they infuse Tregs about 3 weeks after kidney transplantation. I don't know anything about the results. There's nothing on the website about this, and nothing has been published. But this trial has been done. Whether they put all the patients in they wanted to, I know they were targeting 9 patients. I don't know. Then there's 2 trials which are called the task set of trials. These were originated at UCSF in San Francisco. And basically, this is a little bit different concept, but they're using polyclonal T cells to treat patients that show subclinical inflammation in biopsies from transplant recipients about 6 months after transplant. They take and manufacture Tregs from them, and they give them to them. And they're looking to see whether these cells might have a positive effect on the development of inflammation in these patients. One of these trials has been conducted. It's only 2 patients. You can take what you want from that study. It's a bit small to make any conclusions, but they have completed the larger trial, and we're waiting for the results to come from that. It'll be interesting to see. I've got 5 minutes left. I'm going to rush through just a couple more things here. There's another kidney transplant trial. It's called Retire. It's being conducted by Track Therapeutics in Chicago, where they give T regulatory cells 3 months after transplant. I know nothing further about this trial. They're not recruiting yet. So I don't know if there's if this is really going to progress forward or not, but up till now, they haven't recruited any patients. Regarding toll disease and kidney transplantation, only 1 trial that I know of is being conducted in Pittsburgh, and they're using toll disease basically, and they're infusing them from the donor of the kidney transplant 7 days before kidney transplantation. Basically, very similar to what was done in the non-trial. And there are no results from this trial yet. We're going to have to wait to see what the results are. But this, from what I understand, is ongoing. And even the website showed they're still recruiting. Also, there's one CAR T cell trial that is, they say still, no, sorry, I've got that wrong. There is another kidney transplant trial. Although these patients are not receiving a kidney transplant, they're only sensitized kidney transplant prospective recipients. And they're trying to desensitize them using a B cell targeted CAR. As you can see, it's a BCMA CD19 targeting to try to reduce the sensitization. So these patients aren't going to necessarily receive a kidney transplant, whether they see a positive effect or not. They're just seeing whether they're able to reduce the sensitization in these patients. There's the other trial, which is using also a CAR T regulatory cell. It's an HLA specific donor to recipient, a mismatch, and then a CAR, an HLA-A2 CAR. And my understanding is this trial has been stopped. It's not recruiting any longer. I've been to presentations recently where they presented the study, but they give no results. So I have no idea, but I don't think they recruited very many patients into the study. We're going to have to wait for their results to come out. One thing I wanted to mention to you, because I think this is important. This has nothing to do with organ transplantation. Maybe some of you have seen this trial. This is in bone marrow transplant recipients. There's a trial from UCSF or from San Francisco, actually from Stanford based, where they use T regulatory cells to prophylactically to try to prevent acute rejection. Sorry, not acute rejection, acute GVHD. And the reason I mentioned this is because they got, this was just published very recently, they got fantastic results. When they did this, they were basically almost able to completely inhibit the development of acute GVHD. They were able to reduce chronic GVHD, and they were able to give the T regulatory cells in the presence of tacrolimus. So it's really impressive results. If you look here, they went from a rate of about 60% in the control group, and this is prospectively randomized kind of situation, to less than 10% of the patients developing graft versus host disease. I think this tells us two different things. One thing is, we have to understand that we're more likely to have an effect with our ATMPs or Tregs or whatever toll DCs if we use them prophylactically. And this is something I'm coming to believe a little bit more. I think if we put them into a very active situation, we're asking a lot of these regulatory cells to reverse that inflammation that's occurring. And second of all, one of the questions in organ transplantation has been whether we could really give these cells together with a CNI. And I think this proves, at least in the situation of bone marrow transplantation, that you can do this and it has no adverse effects. So to my last couple of slides, what did we learn from the one study? We can bring groups together and design things together and really have a positive effect. In terms of getting data that we can use as a platform to do more trials. The reliability of regulatory cell production, which I didn't mention, a number of the products failed. This is why we had the difference between the 60 and the 38 of those that were recruited into the study and the 38 that were treated because of regulatory cell production methods. But I think these are improving as time goes on. I think we can reduce the immunosuppressive burden and potentially give a positive effect, such as reducing infections. This has to be proven, of course, in additional trials. TAC monotherapy might be a good target if we can reduce that monotherapy to really low levels and keep kidney transplantation recipients on low levels of tacrolimus. This would be fantastic and at least a platform to eventually get to true tolerance in the future. We have to show that there's a benefit of this regulatory cell therapy, and I'll come to this in my last slide, and we have to work together more. We have to design our trials together. We have to kind of decide which cells to go forward and continue to work together. And this is why I think it's important, as you saw, when I went through the different trials that are ongoing, you see such a mixture of different trials that I'm a little afraid, sitting in my seat, that we might get a lot of mixed data and signals from these different trials. I do believe that we have to come together and try to design some larger trials together so we can convince nephrologists to try to, in the future, use cell therapy in their patients. We have, especially in organ transplantation, probably less so in the autoimmune diseases. We have a limited number of patients. We have to deal with cell manufacturing logistics because this probably cannot be done at every site. The physicians question the motivation because they think, well, with the current immunosuppression, we get pretty good results with just immunosuppression and not trying to do any type of cell therapy. So we have to convince them. So we need to show them, we need to decide together with the nephrologist what would be a positive outcome that would convince them to go forward with a therapy that would involve regulatory cells. And there are a number of other things that we need to discuss, but I think there's high expectations in kidney transplantation. If we're going to do this in your average patient, we have to convince the nephrologist that we have some positive results that can be translated for their patients and give them positive outcome that will improve the current situation in kidney transplantation. So this slide is just about, I'm trying to organize actually a workshop with kidney and liver transplant sites that are actually conducting clinical trials right now to try to come together and design a framework for a protocol that you could use for kidney or liver transplantation. So we follow certain standards so that when new trials are done, we can do them kind of in harmony with each other so that we can use our results and compare our results together and get more bang for our buck, so to speak. So this is a one study group. It really takes a lot of people to try to do something ambitious like the one study, and I really have to thank all of them for all their efforts, and I'm happy to take any questions.
Thanks very much, Ed, for a really, really wonderful talk. And it's always good to hear again about the one study and how it worked, and how good an example it is, how international collaboration can move a difficult field forward a lot faster. There's a number of questions actually, and rather than me reading them out, which sounds a bit boring, I would like to ask first of all Shobha to ask her questions, and then John.
Yes, hi, Ed. Sorry, I've put in quite a lot of questions. Very interesting, really interesting talk. And, you know, I'm constantly trying to do some Treg cell therapy with John here. So a few questions that I had were as follows. So basically, I was very interested in the the UK trial where they created polyclonal Tregs. So, and perhaps, you know, maybe you could just refer me back to the paper, but I wondered, how did they generate the polyclonal versus the antigen-specific Tregs in the one study? Would you be able to expand on the granularity of that?
Yeah. So the UK group only used polyclonal T regulatory cells. So they used the standard method for expanding T regulatory cells, right? Nothing extraordinary. They did use rapamycin in the protocol to help. This is they use basically a standard type approach. Now in the US, what they did is they used something called, in Boston, they basically exposed the recipient cells to donor cells. Sure. And had kind of a mixed reaction. You can look this up. If you look up the name of the person on that publication, her name is Eva Guinan, Guinan. She's kind of mastered this protocol, and it's been used by some other groups. And they basically use co-stim inhibition in this mixture. And what comes out is not a pure population, of course, but it's kind of a trained population. And that's what they did. At UCSF, they did a more pure procedure where they used really donor B cells to stimulate the T regulatory cells. But I have to warn you that they had a lot of problems with this.
Oh, okay.
And Kizzy Tang can tell you about that. She's the kind of the mastermind there at UCSF who makes these donor-specific Tregs. They've really suffered over the years with numerous different types of problems. Although they can do it, they use donor B cells in order to get a specific donor-specific cell. I think you raised an important point that I just would like to comment on. After all this time now, 14 years, in the earlier period, I would have bet my money on the need for a CAR, a donor-specific Treg, in order to get an effect. I have shifted in my mind. I'm not so convinced that you need a donor-specific cell. And I've talked to some real experts in the field, and they think, at least in organ transplantation, where we have multiple antigens at work, right? The differences between the donor and the recipient. There's a large faction that believe actually polyclonal Tregs might have a better chance of actually having a positive effect. So I find that interesting. And in my mind, I've shifted too. I think it's a matter of, can you get enough cells in order to have that type of effect? But the second part of that is I'm also kind of convinced that it's going to be very difficult to reverse something that's going on. So I think if you try to give these cells to a transplant recipient months or years after a transplant to try to reverse an ongoing immune reaction, I wouldn't put my money on the table for this. I'm not saying it's impossible, but it's going to be difficult. Okay.
And with polyclonal, you'll get the numbers, wouldn't you? Because 10 million is quite a lot.
Yeah, UCSF group even gave more. They can get cells. They get a lot of cells. They can infuse well over 500 million cells into a transplant recipient. So I think they can get the numbers. It just, yeah, a matter of whether you need the donor specificity or
not. Yeah. I
I
mean,
think that's the big question.
I guess I mean, we are singing from the same hymn sheet here, because polyclonal Tregs, you'll get the numbers. And, you know, if it works, because the antigen specific is a little bit, you know, hard to get the numbers. The one other question I had is beautiful immune hubs, they say. I mean, really beautiful immune hubs in these tissues where you get this immune cell infiltration. Yeah. And we see very similar in our animal models. What we do is, we take an animal, we inject with tumors, and we inject Tregs that do not have PD-1 in them. And those tumors cause also develop these immune hubs. So I'm just wondering, and, you know, perhaps you could direct me to those papers. Have they done the immunophenotyping of those Tregs within the tissue? Because the immune hubs we are seeing are very, very interesting. They're not inflammatory, so it's very exciting for us. And I wonder if you see similar, like, phenotype?
Yeah. So I don't know if you know a guy by the name of Bob Colvin. He's at the MGH. He's a pathologist. He's been working on these tolls for a long time, because he also sees them in the non-human primate models. He's seen them in tolerant patients. He's a real expert on this. He's someone you would want to look up. His name is Bob Colvin, Robert Colvin.
Okay.
But anyway, if you remember, I'm sorry I had to go so quickly. I wish I could go more slowly through some of the slides, but the UK group did, the MGH group did show, you could see it was like a starry sky in those lymphocyte conglomerates, or whatever you want to call them, nodes, that their Tregs are scattered all within there. They don't seem to be in groups. They seem to be individual. What the meaning of this is, we don't know. But Bob would tell me every time I see him, he's convinced that these are really important to establish tolerance in situation of organ transplantation. But this is an explosive topic, because others will say, hey, we've seen these too, and these are patients are rejecting. So we have to be
because we think he's right. Bob's probably right, because we think those Tregs are very important, actually. Yes. But I just wonder if they did any sort of surface characterization of them with co-receptors or
you should look up Paul's paper. And you could also contact Fadi Issa at Oxford, because he's done some of that work and can tell you a bit more about their 12 patients, because they've looked at that. And he's done some molecular analysis as well, and all kinds of different work they've tried to do on these infiltrates. So talk to Fadi. I think John and Catherine, you know who Fadi is. You can help her contact Fadi. Fadi's got some really cool data to show there, so you might want to talk to him.
You know, I've met Fadi once. Thank you so much. Those are my questions. Thank you.
We still have got a few minutes left. John, would you like to ask your question?
Yeah, thanks, Kat. Actually, Shobha's answered one of my questions online, which is great. So I'm just going to ask two quick ones. One is to do with the design, Ed. I mean, the MMF reduction, tapering, I think it was MMF that you taper.
Yes.
Has that been done in a more conventional setting? In other words, is there a comparison cohort to show that that's not possible without the cells?
To answer that question, no, because it wouldn't be ethical. We wouldn't be able to get this through a national authority or through an ethics commission, because they would say it's too risky.
Okay.
And so, John, believe me, I thought about this forever, about how we could design this. And I was always trying to walk the very edge of what I thought we could get away with, right? And this is the very edge of what we can get away with. And this is why, in the end, it's a reference group, not a true control group. They wouldn't let us do it.
I understand that. That's fine. And the other quick question, actually, I is like you, very impressed with the reduction in infection in the one study, and it seemed to start almost from day zero. So is that the basilixizumab that by taking that away, you're making such a big difference? Do you think?
I tried to find a publication that would compare that, but John, I can't find where they've done that and looked at that.
Mm-hmm.
And so the problem is there's not a data set out there to compare to. So you would deduce that though, right? Because
it's the only thing that's different, I guess. Yeah.
Yeah. Unfortunately, you have to realize even the reference group trial, even though that's our standard, there is no trial that's used that as a standard. Can you believe that? It's unbelievable. James Hutchinson and I just dug through the earth trying to find something that it just doesn't exist. It's hard to believe our standard is actually something where a trial has never been done to show what the rejection rate actually would be. It's unbelievable.
Great. Okay, I'll leave it there actually, just in view of time, but thank you very much. Fantastic seminar. Back to you, Kat.
So I've got just one quick question left for you, Ed. So the reduction in immunosuppression in these patients in the one trial that got the cell therapies, was that across the board? Did you find it in all the different cell therapy products, or was it more prevalent in the Tregs?
It was all over, Catherine. I didn't really analyze that specifically, but I'm thinking about every one of the trials. They did it, right?
Okay.
And they had at least a portion of their patients that did. Berlin did it to the highest degree. Basically, they tried it in almost all of their patients, but the others were too afraid to do that. Paul Harden was especially wary of that, and when he saw the other groups do it, and they were having good results, then Paul, in his last 4 patients, this is basically why he has the 4 patients, he did it. And so this is the kind of thing you learn from a trial, right? Things that you can't predict somehow just by looking at the literature. You just have to do it, see what's practicable, and that's the value of doing a trial like this. So I like the idea of TAC monotherapy. And the reason I say that, and that's just a personal thing, I have a brother, an older brother, that got a living donor kidney transplant from my sister. And he's had his transplant now for 34 years. And he got it at the University of Minnesota back in the 80s. And at that point, they had a program where you could go down to very low levels of only cyclosporin, not tacrolimus, no, cyclosporin. And this is what he's been on for 3 decades. And the guy is stronger and in better shape than I am. I mean, the reason I say that is, think about how well you can do on a low dose, a relatively non-toxic dose of CNS. I would never take that off of him, the cyclosporin, because you never know. A little blip, he's exposed to something, triggers a reaction, suddenly the kidney starts to reject. I really like the idea of a low dose monotherapy as protection. And so I hope that that's where we go, at least as a next step in kidney transplantation.
Fantastic. Again, I thank you again, Ed, for giving a very motivating and fantastic seminar. And I hope to see you in person again at some point.
I do too. It was a real pleasure. Thank you, Catherine and John. It was really a delight to be here.
Thank you. Thanks, and thanks everybody for attending.